In this video, we demonstrate a supraclavicular approach to first rib resection, scalenectomy, and neurolysis for neurogenic thoracic outlet syndrome. This is a 32-year-old male who presented with left upper extremity numbness, paresthesia, worsening with overhead activity. The patient completed a course of targeted physical therapy for thoracic outlet syndrome without improvement. An image-guided scalene muscle block provided temporary relief, supporting the diagnosis and predicting benefit from operative decompression. Therefore, he proceeded to first rib resection and neurolysis. The patient was positioned supine on the operating table. A transverse incision is made 1 centimeter above the left clavicle. Dissection is carried down through the subcutaneous tissue and platysma. Next, the investing fascia and underlying clavicular head of the sternocleidomastoid muscle and subclavian fat pad are exposed. The clavicular head of the sternocleidomastoid muscle is divided. The external jugular vein is identified and ligated. Through a combination of dissection and retraction of the subclavian fat pad, superiorly and laterally, the underlying structures are exposed. The most lateral aspect of the dissection is the omohyoid muscle. Just lateral to the internal jugular vein, the thoracic duct is identified. It is ligated with clips. The phrenic nerve is identified and preserved as it crosses over the anterior scalene muscle in a lateral to medial fashion from cranial to caudal. The anterior scalene is then sharply divided at the inferior and superior aspects to perform the scalenectomy. Next, neurolysis of the brachial plexus is performed. First, the posterior and lateral cord, followed by the medial cord. The subclavian artery and thyrocervical trunk is then dissected free to allow gentle retraction laterally using a vessel loop. A combination of electrocautery and periosteal elevator is then used to score and dissect off the remaining anterior scalene and intercostal muscle attachments. The posterior aspect of the first rib is released from the underlying pleura using finger dissection as to not injure or enter the pleura. A rib cutter is then used to transect the anterior aspect, and a rongeur is used to transect the posterior aspect of the first rib. After completing rib resection, a rongeur is used to ensure that there are no sharp edges on the remaining rib. Saline is then instilled into the field and the patient is made to Valsalva. This is a test to ensure that the pleura was not violated. A Blake drain is then placed under the fat pad and brought out inferiorly. The fat pad is then reapproximated, local anesthetic is injected, and the incision is closed in layers. The patient did well and was discharged post-operative day 1. Thank you for watching.